So I've come with another presentation, um, continuing our series of Mrcp basis consultation station. So I'm going to talk a bit about the Cushing syndrome case. Okay, let's start our presentation. So as I told you before also that normally you'll get some information before you go into this consultation station. So that will be written outside. So once you have read it, brainstorm and try to put all the points in order in your brain about what you're going to do, what history you're going to take, what will be the appropriate examination, investigations, and everything. So in this case, there is a 38-year-old female patient, and she has been referred for further evaluation. She have weight gain, facial puffiness, and easy bruising. And she has been feeling increasingly tired and irritable over the past few months. So from this one, you can already have some idea that weight gain, facial puffiness, easy bruising. So these are something we call buzzwords. So you may be thinking about some endocrine problems like Cushing's. Okay, let's move on. So once you have read this instructions, that's you have already done brainstorm. Now you have to take a appropriate history. So you're going to once you enter the room, you begin by introducing yourself to the patient, and then we're going to inquire about her primary concerns. So you can start. You might say that, "Hello, I'm Doctor this one. I understand that you have been referred for further evaluation due to some specific symptoms. Can you please tell me more about what has been bothering you?" And then you give the patient some time, don't interrupt him. So whatever the information which she's allowed, voluntarily allowed to give you, she will give you, and then from there on you can build up the history again. So symptoms and history of presenting illness. So explore the patient's symptoms in depth. For example, you might ask, when did you first notice the weight gain? Could you describe the extent of the weight gain? How quickly it has occurred? And the other patient symptom is facial puffiness. So elaborate a bit more. How has it developed, and is it worse at certain times of the day? About the easy bruising, can you provide examples of when you have noticed this? And then you are also going to ask about the energy level. How would you describe your energy level? Has your tiredness affected your daily activities or work? When did you first notice the appearance of purple stretch marks, and where are they located? Regarding your blood pressure, have you ever had any hypertension before? Do you monitor it regularly? And can you share me more about the changes in your menstrual cycle? So these are all the relevant points which you can ask. So moving on, you're going to ask a bit about the past medical history is important. You're going to inquire about her past medical history to identify any pre-existing conditions that could be relevant. So we're going to ask about any chronic medical conditions or a history of serious illness. So going to ask about any surgeries in the past, or if she's taking any medicines or supplements regularly. Medication history is very important in this because this medication history, she may be taking some steroids, and it could be iatrogenic cause of the Cushing's. So we're going to ask about, are you currently taking any prescriptions or over-the-counter medications? If so, can you list them? And has there any recent changes in your medication regimen? We're going to ask more about the lifestyle factors, about other lifestyle and habits, because this can influence her condition. Could you describe your daily routine, including the diet and exercise habits? Ask about whether the patient smoke, consume alcohol, or use recreational drugs. So once you have made up a mind that the patient has a Cushingite features, and you think that this is a Cushing syndrome or disease, then why we are in the history, some of the main points will lead you to the diagnosis. Like maybe it could be the iatrogenic cause. So Cushing syndrome can be caused by the chronic use of glucocorticoid medicines. We know that. So by taking a medical history, you can inquire about any long-term use of steroids. And the patient hasn't been on this medication, you can just exclude an iatrogenic cause. Then we know that the causes, what are the causes of the Cushing syndrome. I'll talk in detail later about this. One of the causes is adrenal tumor. So detailed questioning about the duration of symptoms and any other associated complaints, this can help distinguish between different causes. Like if you think about adrenal tumors, they may present with these similar features, but they are associated with the sudden onset of symptoms. So adrenal tumors, usually we have a sudden onset of symptoms, while Cushing syndromes, this typically progresses gradually. So a careful history can help establish the timeline of symptoms development. Then if we're thinking about the Cushing's disease, then we will be thinking about the pituitary adenomas. These can also cause Cushing syndrome by overproducing the ACTH. So asking about symptoms like visual disturbances, headaches, or menstrual irregularities may help identify a pituitary cause. Similarly, if you're thinking about some ectopic ACTH production, because this is also one of the cause. So ectopic ACTH production of ACTH by tumors outside the pituitary gland is another possible cause. So inquiring about any known or unknown tumors and the symptoms may provide clue to this. Lifestyle factors I have discussed before, mainly, but still you have to see whether the patient has got some stress or depression, because it can also lead to symptoms that mimic the Cushing syndrome, like weight gain and fatigue. So a detailed psychiatric and social history can help differentiate these causes. Polycystic ovarian syndrome, well, it also comes in the differential diagnosis because it can present with irregular menstrual cycles, and it can also cause weight gain and some hormonal imbalance. So identifying other polycystic ovarian syndrome related symptoms can help rule out this differential diagnosis. So that was all about the history. Then after the history, you're going to take the consent and we proceed with the general examination. Obviously, first of all, you do the look at the appearance. You will note any signs of obesity, especially the central and the facial region, the typical moon facies. In the skin, you check for any facial plethora, redness, any purple striae on the abdomen and thighs, and any thinning of the skin. Buffalo hump, example, the upper back and neck for any fat accumulation, we call buffalo hump. But this term, don't use it in the exam. This is more for memorizing it, that you have to look for these fat accumulation. Cardiovascular examination, obviously, you're going to you're going to tell the examiner that I want to take the blood pressure. Normally the examiner will tell you how is the blood pressure, or they say the blood pressure is normal. So then in the musculoskeletal examination, we have to assess the muscle mass, and then assess for muscle wasting, especially in the extremities. Abdominal examination, going to look for any striae and inspect the abdomen for these stretch marks. In the extremities, we're going to look for any bruising, so see any bruising, which can be a characteristic feature of Cushing syndrome. We're going to check for the proximal muscle weakness, so evaluate the muscle strength, particularly in the proximal muscle. Remember that you have to do a focused examination, so don't forget that when we have to check the visual field as well, because if pituitary adenoma is suspected, we assess the visual field for any abnormalities, as pituitary tumor can compress the optic chiasm. Then we're going to do some pulmonary examination, respiratory rate, note any signs of rapid breathing, difficulty breathing, may be associated with obesity and decreased lung function. Psychological assessment is important, mood and behavior. So just generally assess the patient mood and behavior. And because Cushing syndrome can lead to mood changes such as irritability or depression. So proximal muscle weakness, we already talked about, visual fields, respiratory rate, mood and behavior, such as repetitions. So these are all important examination findings. In this, I like to add, particularly in abdominal examination, you just do the examination, look for the abdominal striae. In addition, look for any previous surgery, maybe any surgical scars there, and palpate the abdomen thoroughly for any palpable masses. So once you have done your examination, um, here I'll just take a break and I'll just talk a bit about the investigations for the Cushing syndrome. Because this, once you do the presentation, you have to tell the examiner about the history, physical examination, what is your plan, how would you investigate, and the management. So I'll come to the presentation part a bit later. So for the hypercortisolism initial screening test, we all know it is 24-hour urine-free cortisol test, and collecting multiple 24-hour urine samples can improve the accuracy of this test. Late night salivary cortisol test. Well, cortisol levels, these normally they drop in late evening, so elevated late night salivary cortisol level can indicate Cushing syndrome. And usually it is repeated on 2 different days to confirm the diagnosis. And then we have a low dose dexamethasone suppression test, in which the patient takes a low dose of dexamethasone at night, and blood cortisol levels are measured the following morning. So in healthy individuals, dexamethasone suppresses the cortisol production. In Cushing syndrome, this suppression doesn't occur, so still the cortisol level will be elevated. Now, these are the basic tests, initial screening tests. Remember these tests: 24-hour urine-free cortisol, late night salivary cortisol test, and low dose dexamethasone suppression test. Then there are some additional tests to determine the cause of the Cushing syndrome. In this, we have high dose dexamethasone suppression test, which help differentiate between Cushing disease. Cushing disease means the cause is pituitary, and ectopic ACTH syndrome. Pituitary adenomas causing Cushing disease will typically suppress cortisol with high dose dexamethasone, while if the cause is ectopic ACTH producing tumor, it will not. Other test is CRH stimulation test. So after injection of the CRH, corticotropin releasing hormone, patient with pituitary adenoma will typically show a rise in ACTH and cortisol level, whereas those with ectopic or adenotumor usually will not. ACTH level measurement, well, measuring the level of the ACTH can help determine if the syndrome is ACTH dependent or ACTH independent. High ACTH level suggests an ACTH secreting pituitary adenoma or ectopic ACTH producing tumor. Low ACTH level suggests an adrenal cause of Cushing syndrome. Then we have some imaging studies, but remember that you all must do the blood tests or all these tests before you go to the imaging studies, because there are incidentalomas. So normally the pituitary studies will be done after doing these tests. So in the imaging studies, we can do the pituitary MRI for suspected Cushing disease to visualize the pituitary tumor, CT or MRI of the adrenal gland to identify an adrenal tumor or hyperplasia, and chest and abdominal CT or MRI for suspected ectopic ACTH production to identify the source of the excess ACTH. Well, petrosal sinus sampling, it is used when other tests can't clearly differentiate between Cushing disease and ectopic ACTH syndrome. And in this, we measure the ACTH level from the veins that drain the pituitary gland and compare them to the ACTH level in a peripheral vein. So a significantly higher ACTH level in the petrosal sinuses indicates a pituitary source. Then we have biochemical tests for ectopic Cushing syndrome. So if an ectopic tumor is suspected but not identified on imaging, tests like the octreotide scan, and there are other tests like the PET scan, they can be used. So this is all about the investigations or the workup which we should perform in suspected Cushing syndrome or Cushing disease. So remember that in your history, once you've done the taken the full history, then you'll do the examination. Then later you have to explore the patient ideas, concern, expectation. You can do it in the first part also, along with the history also, so that after the examination you just be prepared for the presentation. So ideas pertain to the patient beliefs or understanding of their condition. So you might ask the patient, what do you think might be causing the symptoms like weight gain and fatigue? And this question allows the patient to share their perspective and understanding of their health issues. And concerns, which when the patient worries, fears, or specific issues related to the condition, ask questions like, what aspect of your symptoms or health are most concerning to you? And they will express their anxieties or worries about their health and well-being. And finally, the expectations. You can inquire about their expectations, such as what are you hoping to achieve from this evaluation and what do you expect from medical treatment. Now, this helps you understand what the patient anticipates in terms of outcome. So this is you once you have explored idea. Now I have put few notes about the management of the Cushing syndrome. So in Cushing syndrome, the approach typically depends on the underlying cause. Iatrogenic Cushing syndrome, which is due to corticosteroids, then dose reduction or discontinuation. So the patient Cushing syndrome is due to long-term corticosteroid use. The primary step is to gradually reduce or discontinue the steroid therapy. And obviously, we will need the help of the endocrinologist to taper the dose, and even if it is needed, we can stop it. Adrenal adenomas or adrenal carcinomas, well, these are usually managed surgically. In cases where the Cushing syndrome is caused by an adrenal tumor, surgical resection is often the preferred treatment. And we have medical treatment as like mitotane. So it is in the patient who got unresectable adrenal carcinoma, so it can be considered, and the dose is typically 3 to 4 gram daily and can divide into multiple doses and can be titrated based on the tolerance and response. Normally, they will not ask about the doses. Pituitary adenoma, well, this is Cushing's disease. So the management is transphenoidal surgery for patient with for pituitary adenomas causing Cushing disease. Transphenoidal surgery to remove the tumor is the initial treatment of choice, and obviously the approach will be decided by the neurosurgeon. Radiation therapy, well, radiation therapy may be considered post-surgery in cases where complete tumor removal is not achievable. And then we have medical therapies like cabergoline in some cases when surgery and radiations are not curative. So these medications are helpful, and dosing varies and should be guided by the prescribing physician or by the endocrinologist. If the patient has ectopic ACTH productions, the primary treatment is to locate and surgically remove the tumor responsible for excessive ACTH production. Some of the medicines also can be tried, depends on the patient condition, the tumor locations. Medications like ketoconazole or metiropone or mifepristone may be considered. Dosing varies and treatment should be managed by the specialist. And so this is just a general idea about because the treatment will depend on the underlying cause. And then don't remember that patient usually they have some comorbid conditions like hypertension. So if hypertension is present, antihypertensive medications may be prescribed, and choice of medication depends on the patient blood pressure, overall clinical condition. If the patient has osteoporosis, just done some DEXA scan, and they may require bisphosphonates or other bone preserving medication to address the osteoporosis. Psychological and behavioral support. Patients may benefit from psychological support as the condition can affect the mental health, so maybe referral to a mental health professional can be considered. And monitoring regular follow-up is essential to monitor the response to treatment and assess for any disease recurrence. So this is how you will, if they ask you about the management, how you should structure your management. We'll talk about depend on the cause, then briefly you manage few causes, and then you'll talk about management of the comorbid conditions, psychological behavioral support, and monitoring. So how are we going to present the case? Same thing which I told you in my previous presentation. We'll start with the introduction. Good morning or good afternoon. Today I'd like to present a case for your consideration. The case involves a 38-year-old female patient who has referred for evaluation due to concerning symptoms. So you can say this one also because now they are they are also marking about whether you get the consent from the patients. So patient has provided the informed consent for this discussion. Then same thing, you'll like to elaborate more about the presenting complaint. So patient primary concern is significant weight gain over several months, along with facial puffiness, easy bruising and persistent fatigue. She also reported the appearance of purple stretch marks on her abdomen and thigh. In addition, her blood pressure is elevated, and she mentioned irregular menstrual cycles. The patient history reveals that her weight gain has been progressive over the past several months, and she also describes some facial puffiness as getting worse throughout the day. The purple striae has developed on her abdomen and thighs, and she has noticed easy bruising, and her blood pressure has been elevated, and she reports irregular menstrual cycle. So actually, I elaborated it a bit more. So depending on the situation, you can just follow the format that the just give a brief detail about the presenting complaint. Then you're going to mention about the past medical history. So in this case, her past medical history does not include any significant chronic conditions or previous surgeries, and she's not currently taking any medicines. So these are the two important points which you should mention in your presentation. Then medication history is important. The patient is not currently on any medication or supplements. We already mentioned that. Lifestyle factors. The patient daily routine involves a sedentary lifestyle, and diet consists of processed foods rich in carbohydrates. She does not smoke, consume alcohol, or use occasional drugs. So this was briefly about the history, depending on the patient symptoms. We're going to elaborate a bit, but don't give very long history because there is not enough time. So be very precise and to the point. On examination, the patient presents with notable facial plethora, which is more pronounced in the afternoon. There is evidence of fat accumulation on upper back and neck. Avoid the terms buffalo hump or moon faces. Don't do it. The skin on her abdomen and thighs shows multiple purple striae. Her blood pressure is elevated. So based on the clinical presentation and laboratory and imaging findings, if you have any idea about the laboratory findings, or if the patient maybe in the history you'll ask what tests you've done, patient may show you some tests or some imaging findings report. So the working diagnosis is Cushing syndrome. If there's no laboratory or imaging findings you don't have, then you will just talk about your diagnosis, and then you're going to brief it about the differential diagnosis. So in the differential diagnosis, we consider different diagnoses like iatrogenic Cushing disease due to medication use, adrenal tumors, pituitary adenomas, ectopic HGH production, and other conditions that can present with similar symptoms, like we talk about the polycystic ovarian syndrome. So management will include addressing the underlying cause in this case. So I made this case as right adrenal adenoma. So the patient has right adrenal adenoma. Maybe they show you some ultrasound or some findings. So it should be managed through surgical resection. Following the procedure, close monitoring of the patient cortisol level and resolution of symptom will guide further management. So this is how should be your presentation. So you're going to start with the history, your presenting complaint, past medical history, medication history is very important. Briefly talk about the examination findings, your differential diagnosis, and the management plan. Some of the common questions which the examiner may ask regarding this case. So examiner can ask, can you describe the key clinical features that are suggestive of Cushing syndrome in this patient? So your response, this is one of the example. The patient presents with several hallmark clinical features of Cushing syndrome, including significant weight gain, facial puffiness, the appearance of purple striae on her abdomen and thigh, easy bruising, and elevated blood pressure. So these findings are suggestive of excess cortisol production. Another question which the examiner may ask, how is the diagnosis of Cushing syndrome confirmed in this case, and what do the specific test results indicate? So the diagnosis of Cushing syndrome in this case is confirmed through a series of tests. The 24-hour urinary free cortisol measurements reveal significantly elevated cortisol level. Again, I have just made up these things. Depends on this condition. If the situation, if they have already shown you some tests, then you will describe that what the test results were. If they didn't show you, then you just mention the tests only. So elevated cortisol levels is a common marker for Cushing syndrome. Additionally, serum cortisol levels are elevated. The low dexamethasone suppression test showed a lack of cortisol suppression, and the abdominal CT scan identified a right adenoma, which is consistent with the source of cortisol overproduction. Another question which examiner may ask, can you explain the differential diagnosis you consider for the patient? How did you rule them out? So in the assessment, we consider several differential diagnoses, including the iatrogenic Cushing's due to medication use, adrenal tumors, pituitary adenoma, ectopic ACTH production, and other conditions with similar symptoms, like polycystic ovarian syndrome, or maybe because of the depression on this. In this case, we ruled out iatrogenic Cushing's because the patient was not taking any corticosteroid medication. The presence of a right adrenal adenoma on the CT scan supports the diagnosis and excludes pituitary adenoma. And we're not aware that this patient has any ectopic tumors contributing to ACTH production based on the clinical presentation and available investigations. Okay, so then another question which examiner may ask, what are the primary treatment options for this patient and what is the anticipated outcome of this treatment? So primary treatment, we're talking about the Cushing syndrome. So primary treatment for this patient, given the diagnosis of Cushing syndrome due to right adrenal adenoma, is surgical resection of the adenoma. Once the tumor is removed, cortisol level should return to normal and the patient's symptoms are expected to improve. Close post-op monitoring of cortisol level and symptom resolution will guide further management. So in cases where surgery is not curative, other options such as medical therapy or radiation may be considered. So the idea of my presentation is just give you some food for thoughts, and you have some idea that how you should structure your presentation, how you should approach your examination, and what are the salient points for the history taking. Obviously, the symptoms, and you're going to alter it according to the patient's symptoms and according to the situation. Okay, so that's it from my side. Furthermore, I'd like to request that please just write in the comments if you want any particular condition or disease to be discussed for this. I'll be very happy to do it for you. Otherwise, I'll continue doing my presentations and making videos for the common cases which I've seen, and also discuss with my colleagues who have already taken this examination, like what are the common cases which usually present in the consultation session. Okay, thank you very much, dear doctors, and take care of yourself.